entropion, inward turning of eyelid margin. It can be either acquired or congenital. In congenital, we do the Hotz procedure, tarsal fixation. Acquired can be involutional, cicatricial, or acute spastic. Involutional, the most common mechanism is the overriding of the preseptal over the pretarsal. This is the preseptal portion and pretarsal. This is the overriding shown here. So this is the most common mechanism, and most of the surgeries prevent to overcome this mechanism. Then other mechanism are horizontal lid laxity, weakness of lower lid retractors, and tarsal or orbital fat atrophy, etc. Management, transverse lid diverting sutures is done as a temporary management, and if it is more than 18 months, then permanent management is done. If there is no horizontal lid laxity, then Weiss procedure is done. If it is with laxity, then Quickert or Jones procedure is done. Then there is cicatricial entropion. It can be either infective or non-infective. Infective, most common cause are trachoma, bacterial infection, and viral infections. Non-infective, most common cause are Steven-Johnson syndrome, ocular cicatricial pemphigoid, chemical injury, thermal injury, and drug, because of drugs. Now it can be mild or severe. If it is mild cicatricial entropion, that is less than 1.5 mm, we do a tarsal fracture. If it is severe, more than 1.5 mm, we do a posterior lamellar graft. Entropion, coming to the treatment part proper, the temporary treatment is usually we do a transverse lid diverting suture. Here the main aim is to overcome the overriding of preseptal over the pretarsal orbicularis oculi. The procedure is we use a double arm 4-0 catgut, enter from conjunctiva to skin, and just below the tarsal plate, 2 mm apart between the two arms, then exit through the skin just above the level of conjunctival entry. Next is a Weiss procedure. It is a permanent procedure. It is a combination of transverse lid diverting suture plus transverse lid splitting. Here the transverse lid split is given a full thickness transverse eyelid split. It creates a fibrous scar which acts as a barrier between the preseptal and the pretarsal orbicularis oculi. Level of transverse lid split is about 4 mm below lid margin to avoid tarsal plate. Now transverse lid diverting suture, again same, we give a double arm using a double arm Vicryl 4-0 or catgut 4-0. We enter from conjunctiva to the skin 2 mm below the cut edge through the lower lid retractor and enter the upper portion between the tarsal and orbicularis oculi. Exit through the skin 2 mm below the lash line. Skin closure is done with a 4-0 Vicryl. Next one is a Quickert procedure. In Quickert procedure, it is a combination of Weiss plus horizontal lid shortening. Here horizontal lid shortening, we cut a portion of lid margin 5 mm from lateral canthus and a transverse lid split. That is a full thickness transverse eyelid split. It creates a fibrous scar which acts as a barrier between preseptal and pretarsal orbicularis oculi. Level of transverse lid split is about 4 mm below the lid margin to avoid tarsal plate. Align the cut lid margin with Vicryl 4-0. Then next is the Jones procedure. In Jones procedure, we do the plication of the lower lid retraction, which creates a barrier against upward movement of the preseptal orbicularis oculi. Here the procedure is horizontal skin incision 6 mm below the lid margin is given. A blunt dissection is done to identify orbital septum, divide the orbital septum, retracted orbital flat, lower lid retractor is behind the orbital fat, and confirm the lower lid retractor and catch lower lid retractor and ask patient to look up and down to feel the tug. Now enter pass the 4-0 catgut via the lower skin edge to catch the orbicularis, lower lid retractor, and come out. Then again enter superiorly to catch the tarsal plate to exit through the skin superiorly. See here it is given. Now next is a cicatricial entropion. In cicatricial entropion, in mild cases we do a tarsal fracture. Mild cases, the tarsal fracture, here we give a transconjunctival incision to divide the tarsal plate. Then a double forearm 4-0 suture is entered below the cut end of the tarsal plate, then exit through the skin. Disadvantage of this procedure of the skin approach, it is also there will be necrosis of lid margin. Coming to the next one, if it is a severe of the tarsal fracture procedure is failed, then we go for a posterior lamellar graft procedure. Here the tarsoconjunctival incision is done to divide the tarsal plate, and also then we do a free inferior edge of the tarsal plate, orbital septum and lower lid retractors. These things will free it, and then free them from the orbicularis oculi muscle. Then insert graft between the cut tarsal plate. The graft can be donor sclera, buccal mucosa, tarsal plate cartilage, then or a transconjunctival composite graft, etc. Then secure graft with 2 sutures. First, upper edge of graft to cut upper tarsal. Second, lower edge of graft to cut lower tarsal. That's it.